All right, well, welcome. Good morning. I'm Gervin Sadhu. I'm one of the fourth-year residents here at ETSU. Most of you already know me in the room. Today I have the pleasure of introducing my colleague, Dr. Samar Abdel-Jabbar. She'll be presenting on this lovely topic of cannabis. She did her undergrad at Nova Southeastern University. She did her Bachelor of Science in Biology, followed by medical school at Ross University. Of course, she's finishing up her residency here at East Tennessee State University. Unfortunately, she'll be leaving us soon for a fellowship in child and adolescent. She's going to University of Florida, so we wish her best of luck on that. And so please give her a big round of applause.
All right, you guys can hear me? All right, even back there? All right, thank you, Dr. Sadhu, for the introduction. So today my topic is about cannabis involvement in adolescence, patterns, pathway, and potential outcome. My mentor for this presentation is Dr. Bird. See if I could. All right, so disclaimer, I have no disclaimer. So today's objective is to become familiar with the changes in marijuana use and its potency over time, to review the latest study on the risk, protective factors for the development of marijuana abuse in adolescent, to assess marijuana's effect on the developing brain of adolescents, to understand the possible adverse health effects of short-term and long-term use of marijuana in adolescents. All right, so let's dive in. So before we do, I just want to clarify some terminology. So there are two types of derivatives from cannabis sativa, specifically hemp and marijuana. Hemp is commonly grown in the colder climates, and they have high level of CBD, which is also known as cannabidiol, and low levels of THC, which is tetrahydrocannabinol. Marijuana is grown mainly in warmer climates, and they have lower CBD levels and higher THC levels. And you guys are probably familiar with marijuana being called as pot, weed, grass, 420, herb, joint, blunt, reefer, Mary Jane, MJ, the list goes on and on. So cannabis is the world's most popular illicit drug. It's the second most popular illicit drug among adolescents right after alcohol. So in 2017, a survey was released called Monitoring the Future through drugabuse.gov, and it was conducted by researchers at University of Michigan. They had about 45,000 students from over 300 public school and private school participating in the survey. What they found was that 35.6% of 12th graders have reported using marijuana at least once in the last 12 months. Which wasn't much of a change since 2010, but there was at least a 3 to 6 timefold increase in their low point in 1991. From 1996 to 2016, daily marijuana use, and here in this survey, they defined it as using marijuana on 20 or more occasions in the last 30 days. Students, mostly in the 8th and 10th and 12th grade, 8th graders reported about 0.8%, 10th graders reported about 2.9%, and 12th graders report 5.9%. Interestingly, also in this survey, they asked the students what they thought was in their e-vape cigarettes, if it consists of marijuana or oil hash. And what they reported was 8th graders reported about 8.9%, 10th graders reported about 10.7%, and 12th graders reported about 11.1% that believed that there was marijuana in their e-vape. With 32 states and counting having legalizing medical marijuana, there was a question, is there an increased use of marijuana in the adolescent population? Dr. Aster Koo from Brown University conducted a research of over 11 million high school students and asked them that question. What they found was there was no increase, given the fact that the laws had been passed. And this was published in 2014. Also, a similar study was conducted by Deborah Hassan at Columbia University, and they as well found no apparent difference in marijuana use when the laws were passed in 2015. So cannabis is a plant-based product, originated back in the ancient world. It has coexisted with us for years. As evidence has suggested the use of it more than 5,000 years ago. It was first used medicinally around 400 AD. So I would like to bring your attention to kind of like the pattern where marijuana has traveled. First, it started off in China, where it was used for food and pottery. Then it went to Russia, then from Russia to the European countries, and then from there it split and then went to Iceland with the Vikings, and then to the Middle East, where it was used for paper and edible items. And then from the Middle East, it went to India, where it was used for a holy drink. And then from India, it went to Africa, where it was used medicinally as well to use to boost courage before the battle. And then from there, it traveled transatlantic with slave traders into the Americas in 1616. The picture here on the right has an interesting story. According to a study published in 2008 in the Journal of Experimental Botany, a 2,700-year-old stash was uncovered from an ancient tomb in northwest China. Initially, the researchers thought that it was coriander. And then after excavating all that hash, it took about 10 months from China into London, and once they run it through the microscopic botanic analysis using carbon dating and genetic analysis, they realized that the herb was really pot. So this is like the oldest pot that we have out there. So you wonder, any pot smoker will probably be happy to get that. But they did study that, and it did decompose, so there will be no high if they were to smoke it today. All right. So we left off where it entered. Ooh, what did I do? Sorry. We left off at where the cannabis has introduced was into America. So in the 1700s, American farmers in several colonies were required by law to grow hemp. Hemp was so important in early America that we used it for food, rope, clothes, sail, paper, fuel, and constructive material. Even towns across the country named themselves after it, such as Hemp Hill, Georgia, Hemp Hill, Kentucky, Hemp Ridge, Kentucky. In 1753, Carl Linnaeus, a Swedish botanist who created the modern system of classifying organisms, named the plant Cannabis sativa. They grew tall and had thin leaflet, and then later on, Cannabis indica was discovered in the colder mountains of India. And then this little guy right here was discovered in Russia, and that's called Cannabis rudalis. What Carl Linnaeus found interesting is that while most plants have both male and female part, cannabis, on the other hand, had either plants that produces seed, whereas in other plants producing pollen, either they're a male or a female plant. And the female plants are the ones that have the highest flower. So this is the flower right here in the female. And they're the ones that produce the most psychoactive resin and oil. So the leaf and the stems do have some psychoactive ingredients in there, but not as much as the flower. So let's fast forward about 2 centuries later. So we're here in 1970. The Controlled Substance Act classified hemp as an illegal Schedule I drug, which imposed strict regulations on the cultivation of the industrial hemp as well as marijuana. President Nixon went on and created the DEA in 1973, after noticing an increased influx of marijuana from Mexico to California. And the agency's responsibility was to track drug use and the smuggling of it in the United States. The thing was that the cannabis that was coming from Mexico to California was the weak kind. Most of the smokers got the leaves and the stems, and they were not too happy about it. So American marijuana farmers decided to actually start growing it on their own. But the problem was that Cannabis sativa can grow up to 10 to 12 feet tall, and drones were able to spot it easily and uproot them. Well, they were determined. So they decided to crossbreed this Cannabis sativa with indica and rudalis. And what they found was they were able to make a smaller offspring that was small enough to hide indoors. And not only did they were able to hide it indoors, but they were able to find a different kind of new high. And that kind of brings us to this magazine here. So this magazine is titled the High Time Top Magazine. It issued the top strands in 1977. And these were the first offsprings from the origin of these original cannabis sativa, indica, and rudolphis. And it's probably a little too small there, but I've listed a few. Colombia Gold, Thai, and Hawaiian were a common strain at that time. But the crossbreeding did not stop. It continued, crossbreeding, crossbreeding, and crossbreeding, and it brings us to what we have today. Some of you might commonly know Pineapple Express, there's a movie on that, as well as Blue Dream, Green Crack, and Gorilla Glue. So what makes them unique is something called the cannabinoid profile. So the cannabinoid profile has two types of category, the active ingredient and the non-active ingredient. So in your active ingredient, you find your THC, CBD, CBG, CBN. And then your non-active ingredient, you find your tryptophan, which is also your aroma molecules, and your flavonoid, which is your flavor molecules. All right, so let's imagine you're about to create your own first genetically modified marijuana strain, and you're gonna set it out to the market. So we're gonna have this big mixing bowl. I mean, that's how they do it, right? A mixing bowl. So you're gonna pick and randomly any percent you would like. So I'm gonna say 20% THC, 10% CBD I'm gonna put in there, maybe 0.2% of CBN. And I'm gonna pick from the flavors down here, the lemon one, lemonin. And I'm gonna put in some lemon in there. So now I've created my own genetically modified strand, and it has a citrus taste to it. And I'm gonna name it Lemon Haze and put it out in the market. So now you can see how it's really hard to track and monitor these different types of combination. So an unregulated product that has rapidly changing genetic modification means that people don't really know what they're buying. And we're just starting to understand the health consequences that we're starting to understand. So the DEA has been on top of it. They have been monitoring marijuana, and they've noticed about a 3 times more potent as it was in the mid-90s. And they continue to keep tracking it in the United States. But not only in the United States, other countries are doing so as well, in the Netherlands, United Kingdom, and Italy. In 1995, the average THC potency in a leaf was 3.6%, and it has jumped to a 12.5%. In the 1990s, the average THC content in a hash oil was roughly 13 to 16%, and that has jumped to 52%. There was one recent sample where they found 82% in the oil. So the THC content in a flower back in 1970s was 11 to 1. Now it's 250 to 1. What do our adolescents think about that? What's their attitude towards marijuana? Well, that survey that I mentioned earlier, the one monitoring the future, they asked them that. They've asked high school students about their perception of marijuana use as harmful and their disapproval of regular marijuana use. Only 31.1% of 12th grade students reported perceiving regular marijuana use as being harmful, which represented a 46% decline since 2006. However, the disapproval of regular marijuana use is decreasing but remains high at a 68.5. There are legal implications. So it is illegal for anyone under the age of 21 to buy, possess, or use retail marijuana. Youth caught trying to buy, sell, or use marijuana can face a minor in possession charge. This can result in fines, public services, education and intervention, loss of driver license, and also maybe a misdemeanor or a felony charge. People under the age of 21 can face charges that have lasting impact. Some of them might cause a loss of financial aid toward their education. Oh, sorry. So from 2012 to 2014, the arrest rate of white juveniles with marijuana offense fell 9%. At the same time, marijuana arrests jumped to 26 to 58%, respectively, in a Latino and Black, according to a report produced by the Colorado Department of Public Service. So there is some disproportion there. So given the prevalence of illicit substance use in adolescents in the United States, the far-reaching medical and psychosocial consequences, there is an intense national debate about the appropriate methods to combat this problem. Arguably, the most controversial debate is centered onto school-based drug tests of adolescents. The consequences of a positive drug test may result in some punitive measures, may need further student assessment, counseling, therapy, or rehab. According to the National Institution Out of School Time, students who spend time in after-school activities are 49% less likely to use drugs. Students involved in illicit drug may decrease their involvement in these activities because avoiding drug testing. And without such engagement, adolescents are higher likely to maybe drop out of school, possibly getting pregnant, joining gangs, pursuing and increasing their drug use, or engaging in other risky behaviors. Another note to keep in mind is that a positive drug test may also cause increased conflict at home rather than improving the situation for the kid. Drug testing youth who are not implied using drug can find that very unfair, and they also may reduce their trust and connectedness to the school. And that is really a concern given that you want to maintain open communication. There are screening tools for a healthcare provider. A healthcare provider should maintain confidentiality when screening in adolescents. And there are screening tools that do help in this area. Screening tools are not diagnostic. They are just brief instruments to help determine which marijuana user may benefit for a more thorough diagnostic assessment. In general, screening tools are better at scoring frequency of use rather than the consequences of chronic use. Here are some samples of some screening tools. So the SDS, which is the Severity of Dependence Scale, is a general scale for diverse drug. There are some conflicting opinions about it being utilized for adolescents. The popular one is CAUDIT, which is the Cannabis Use Disorder Identification Test. It's been tested in general population and specific user samples. It's not a diagnostic measure, but it does distinguish between the difference between the levels of cannabis use and the problem rate severity, and this may facilitate matching patients to treatment intensity. There are two types of screening tools that is used outside of the US, the CAST, which is commonly used in France, and then you also have the CUPIT, which is commonly used in Australia, and they use that for adolescents and adults. And then we have the CRAFT, which is commonly used in the United States for adolescents for substance use, and that is general substance use, not only marijuana. There's no tool better than the other, it's just a preference. But however, it is important that the healthcare provider should consider referral to an addiction specialist to further treatment and evaluation if there is concerns about mental or physical or social concerns. In 2017, Substance Abuse and Mental Health Survey Administration released a thorough, long pre-review PDF. It's 24 pages long. I do have the website on the PowerPoint, so if you guys want that link, you're more than welcome to get it. It's pretty long. So it talks about the risk and the possible potential outcomes. I've just highlighted a few here. So aggression or disruptive behavior may possibly lead to outcome of marijuana or cigarette exposure. Hostility from their substance abuse fathers may increase the risk of early onset of marijuana use. Bullying at 5th grade may increase the risk of marijuana use at age 21. And that one I kind of want to highlight the bullying. This one was where they've conducted a national cross-section of about 2,000 adolescents, and they were looking at 48 different countries, also throughout Europe, so it's not only US, so it has a good mixture. And where they found is that they found both the bully and the bully victim, both were increased the risk of possibly early marijuana use. School dropout also can lead to possibly a moderate marijuana use. And here, this was interesting because there are some studies that showed that not only marijuana could lead to drop out of school, but there also a question, is there a low education already like pre-existing prior to marijuana use, and then kind of marijuana use kind of highlighted that, and then therefore there was that dropout. And also there was another article released in 2002 that showed peer association and attitudes towards schooling. And if that attitude was pretty negative, then their likelihood of dropping out with marijuana use involved as well there. So it's not really clear. So self-control problem at grade 6, marijuana use, possibly marijuana use in grade 11, attention problem at grade 6, as well as maybe possibly use of marijuana at age grade 11. So perceived rejection response upon disclosure of sexual orientation may lead to possible marijuana use. And here there was a study that was recently released this year by Dr. Amelia in 2019 titled Sexual Minority Youth at Risk for Early Persistent Alcohol, Tobacco, and Marijuana Use. So this study had showed all three substances. So that's something kind of tricky. But here she looked at about over 300,000 students using the Youth Risk Behavior Surveillance System. And they basically asked one question about their sexual orientation, and then from there about their substance use. And then it showed that female lesbian and bisexuals were at a higher risk of initiating a substance, marijuana or tobacco, and tobacco, and over time versus a heterosexual female. And then a male youth with partners of both sex are at greater risk to persist their use of tobacco, alcohol, and marijuana use. Delinquency, also possibly lifetime use of marijuana, victims of sexual abuse by peers or adult or by a caregiver may increase the risk of marijuana use, and poor emotional health / depression between the age of 12 to 14 years old may increase the risk of marijuana use. So not only did they talk about the risk in this PDF file, they also talked about the protective factors. So the protective factors here are academic achievement, positive youth development, and they define that as an intentional pro-social approach to engage youth within their community, school, organization, peer groups, and family in a manner that's productive and constructive, recognizing, utilizing, and enhances the youth strength and promote positive outcome for young people by providing opportunity, fostering positive relationship, and furnish the support needed to build on their leadership strength. I think all kids need that, right? But anyways, the importance of religion, family routine, ritual involvement, and also parental monitoring. And in this study, what they mentioned was that the family routine was having dinner every day at 6 o'clock. So where they had to be at home at that time. Higher parental education, quality family relationship, closeness to parent, and engagement in school and environment. All right, we're going to shift gears a little bit and talk a little bit about the neurophysiology and neuroanatomy of cannabis. As we've already established, that marijuana has a main psychoactive chemical called THC and a second major active chemical called CBD. But cannabis has more than 100 compounds that affects the human body, and they're called cannabinoids. A few decades ago, researchers discovered that we produce a lot of the similar chemicals naturally, and we have receptors of them scattered throughout our body, and they're called endocannabinoids. It involves in food regulation, cognition, and fine motor movement. The endocannabinoid system is found in every animal except for insects. We still do not fully understand why they're there, but there is evidence that they play a key evolutionary role in regulating appetite and reducing stress. So an active ingredient in cannabis sativa, you may have the feeling of bliss, euphoria, and peacefulness, which strengthened the hypothesis that endocannabinoids might mediate the central and the peripheral effects of an exercise. In other words, they might be the chemicals behind the euphoria you feel when you exercise. So there are two type of receptor subtypes known as CBD1 and CBD2. They are part of a large class of G protein coupled receptors, and they were roughly designated by their location. So CB1 mainly is in the central, CB2 is mainly in the peripheral, respectfully. So CB1 receptor, as I mentioned, is mainly in the CNS. You can find them in the basal ganglia, the cerebellum, neocortex, hippocampus, and also a small proportion of them are found in the immune system, and also the peripheral nervous system, the heart, small intestines, prostate, uterus, bone marrow, and vascular endothelium. CB2 receptor are predominantly found in structures related to the immune system. So you find them in the lymphocyte B and T, monocytes, macrophages, also in the glia cells in the CNS and the spleen. And to some lesser extent, you might find them in the heart, endothelium, bone, liver, and pancreas. One study saw that the CB2 receptor in the CNS that present mainly in the glia cells do upregulate about 100 times more when they're facing an inflammatory process or after a tissue injury. Endocannabinoids that are released by neurons during heightened neural activity also interact with axon terminal CB1 receptor via retrograde transmission to inhibit an afferent neurotransmitter release of GABA or glutamate. So the activation of CB1 receptor can also initiate long-term forms of synaptic plasticity. So in a case of where someone's exposed to long-term steady marijuana, you might find two phenomena going on. One of them is called the long-term depression, where there will be prolonged low-intense stimulation leading to weakening of synaptic connections. And that will lead to downregulation of CB1 receptors at the synapse. Another type of phenomena is the modifying the strength of the prolonged potentiation. And it does that by reducing the phosphorylation of CREB, which is also known as the cyclic AMP respond element binding protein. That's this right here. And it is a cellular transcription factor. So it can reduce the phosphorylation of that, leading to also downregulation of CB1 receptor. Interestingly, that kind of brings up the topic about epigenetics. So does marijuana affect that? There was two studies that was conducted in children where they looked at the methylation of the DNA promoter and questioning, could that be from the marijuana use and does it lead to schizophrenia? And there was no relationship there. Also, there was one study they did on rats, and it was similar. They were looking at the methylation of DNA and questioning if that increases the risk of schizophrenia or psychotic symptoms or depression, where they saw that where the rats would isolate and not socialize, and that didn't happen either. So that was also negative. All right. So, but there is one study that also mentioned that when they were studying the cortical brain, and they saw that there was a lot of selective downregulation of CB1 receptor after a long-term use of marijuana. They were doing it for years. They didn't specify the years. The years was pretty wide range. They said plus or minus 5 years. So, and then what they found is that when they were abstinent for 4 weeks, the regulations came back up. The CB1 receptors were back. So it is reversible there in that study. So we're going to talk about the possible effects of cannabis on the brain structure. We're going to highlight 3 different sections: the gray matter, white matter, and the blood supply. So these are possible effects that cannabis can do on the brain structure in the gray matter. They can decrease the right medial orbital prefrontal cortex, might decrease the concavity of the sulci of the frontal, temporal, and parietal lobe, smaller right hippocampus volume, increased amygdala volume, or larger cerebellar volume. However, there was a lot of studies that did not support this. So they had issues reproducing the same results. So there is that, some report that there is an altercation in the gray matter, but a lot of them were inconsistent in evidence and when they're viewing it in a functional structural MRI. And a lot of the studies also highlighted there's a lot of co-founding factors, like mentioned in a lot of the earlier slides. There's the use of tobacco, maybe alcohol. Also, there's a lot of psychosocial issues that can contribute this. So there is, it's definitely not clear cut. And another thing was also they mentioned was the range of population. So they had age groups like from 16 to 30. So we kind of got into, out of that range there. And another thing that was also different from every single study was their definition of heavy use or long-term use. So there was one study that said use of 100 in a lifetime, 100 days in a lifetime. So I don't, if they're 16 or 18, I mean, that's not much. And then another study said 200 days out of a year. And another study said, maybe this one's probably more daily, or I guess heavy use is 20 days in a month. So, and that kind of, so there was definitely a wide range on that. So definitely there is a need for a study, a larger longitudinal study, where it has more of a diverse selection of people, also, considering other roles, the sex, psychopathology, genetics, sleep, and other initiation of also the onset of substance use. Some of them were onset later in their age, like adolescence, so maybe like around 15, 16 versus like a 13-year-old. All right, how about the white matter? So literature does show that an increase in white matter throughout a developing brain, and that's what you would wanna, that's the aim that you would wanna for a healthy kid. And what they use is a diffuser tensor imaging, which is DIT, which commonly uses two indices, which is the fractional entropy, FA, and the mean diffusivity, which is MD. And it's thought that those are the two indices that we use to identify altercations in a healthy white matter. So in a healthy white matter development from a young child to early adulthood, you would want to see increased FA and decrease MD. So what is FA? FA basically is range from 0 to 1, and it studies the movement of water. So the closer you are to 0, that means there's too much water movement in that area. The closer you are to 1, less movement of water. So if you guys can look at the picture to your right, the top and the bottom. So the top picture has more myelin, so there's less water movement in the white area. And then the bottom one had more fiber bundles, so therefore there's less movement in the white area. And that's typically what you want to see in a developing brain of a child. You want more myelin, more fibers, so that just looks better development. As if you look on the left side of that picture, the top and the bottom, they have less myelin on the top, less fiber bundles on the bottom, therefore more water movement, so the FA goes down. So MD is the diffusion of water into the cell. So you see increased MD in edema and inflammation, and you see decreased MD in neoplasm cancer. So typically you want to kind of range in the middle. That's where you would want. So some studies showed the opposite. They see decreased FA and increased MD. And I'm here to confuse you, right? So of course there's some studies that show that doesn't exist either. So there are a lot of studies actually that showed that they found no evidence of pathology of white matter despite the difference between marijuana users and non-marijuana users. One study showed, which is quite interesting here, that users here between the age of 16 to 19 years old, they used marijuana and alcohol, but binging alcohol, and they found binging had worse indices in the white matter. So again, we need further studies to understand not only marijuana's use on the brain, but also other substance use on the brain. How about blood supply? So to my knowledge, I found 2 studies, and they're really small studies. They're case studies. They had small participants, only 23, and here was the lifetime user of 200 use of marijuana days. And the age range here was also 15 to 21. And here they found reduce in cerebral blood flow in the 4 cortical regions, and they found an increase in the right buccaneus at baseline. There's also one study that showed that there was no difference in neurovascular functioning after abstinence of marijuana. That's right here in this one. And then they also noticed that there was probably an acute reduced blood flow only on acute use of marijuana, not long-term use. All right, adverse health effects. We're going to highlight the short-term use and the long-term use here. All right. As noted, the use of cannabis by young people is very common, and nearly 35.6% of young people use marijuana before the age of 21. However, much of the problem of the use of cannabis is likely confined in less than 10% for those who use heavily or long-term. So the literature, there's nothing in the literature that says death in marijuana, either long-term or short-term. However, for acute symptoms, children may have impaired short-term memory, making it difficult to learn and retain information, impair motor coordination, interfering with driving skills, and also risk of injuries, altered judgment, increased risk of sexual behavior, facilitate transmission of sexual transmitted diseases, and in high doses, and especially the marijuana strain that has the most THC, will most likely possibly cause paranoia and psychosis. Okay. So the potential adverse effect of long-term and heavy, and I put those in quotations there because, like I mentioned earlier, that there is an issue with standardizing what is one puff, what is one blunt, whereas we are able to standardize a shot of, hard liquor like, vodka versus, pack of cigarette. We know what's in a pack of cigarette, whereas with marijuana we don't. So the scientific literature on marijuana and adverse health effect is by no means clear-cut. So only until recently, cannabis was viewed a pretty harmless drug with a few side effects. But in the last 2 decades, there's just been a lot of some studies that say, yeah, maybe not. There might be a little more, especially particularly used in an adolescent age. So the first point, we kind of talked a little bit about that already, about the brain, but I'll throw some studies here. So in an animal study where a young rat was exposed to THC, they had problems with memory and learning later in life. That was done in 2016. And another study found that young rats were repeatedly exposed to marijuana and they had trouble forming new memories as they transitioned to adulthood. And what they found in that study also that rats had more anxiety and less desire to socialize. So as you can imagine, maybe you've guessed, smoking, because any type of inhalant would damage the lung. And there wasn't any study that said about cancer in lung, and though there is an article later which I'll highlight on the next slide, but there is a concern about increased risk of chronic bronchitis, and that's just because of trachea, burning the epithelial line there. There was a study conducted by a researcher in University of California, and they found marijuana does not damage lung as tobacco does, but what they found was occasional use of marijuana does not damage it, and then they said heavy user will most likely damage the lung, but they didn't have enough of a population that smoke heavily for them to actually validate their conclusion. So the risk for psychosis, this number changed from each paper to paper. So I probably should have put a range there. There was some paper that says 1.5, other paper said 2.5 times higher. This one said 7 times higher. There was also one study that found there was no risk. And I mentioned earlier with the methylation of the DNA, there was no risk there either. So that was something but there was one thing that possibly did mention is that if you have the genetic predisposition to have most likely or possibly might have schizophrenia in the future, smoking marijuana at a younger age might increase your risk. So it may allowing an earlier onset of psychosis. All right, and then here, the fourth, So here they talked about the anxiety and depression. And this was a lot of these studies had a lot of confounding factors. A lot of them did not contribute the psychosocial, their sleep, the other underlying mood disorders. There was one study in 2014 by Brian Wooms and his team. They've developed using the Developmental Pathway Project. They had samples about 521 middle school students that indicated increase in substance use can predict possibly increased risk of conduct use symptoms in 9th grade, and then also can persist into 12th grade. But what they found in that study, that it failed to predict any depression symptoms later, and it didn't differ, there was no difference between a boy or a girl. All right, and then in 2016, Dr. Jackson and his team had a study of 2 longitudinal twin study around about 1,241 participants. And in there, they had ages between 9 and 10. And they found that there was no decline in IQ. And then that was one of the points down there, decline in school performance. They found there was no decline, direct result of marijuana exposure would cause decline in IQ, but rather for familial factors that may underlie both marijuana initiation and low intellectual attainment. Another study also studied the early onset of chronic cannabis use exhibited poor cognition performance than controlled and late onset user and executive function. The chronic cannabis users would start before the age of 15 that may cause damage to the neurocognitive function. Another study also in Duke University by psychologist Dr. Moffitt and her colleagues, they looked at 1,000 New Zealanders, and they saw that there might be also a decline in IQ, roughly 6 points. And that was released in 2012. So the literature is really confusing out there. So how confident are we? And according to a New England Journal of Medicine in 2014 by Nora Volk and her team, they released a review article of adverse effect of marijuana, and they reported this right here. So in her article, she didn't mention what is high and what medium and low, what she means by that. So she just had those numbers there. Words there. And so this kind of brings up the concern, or the question, we need a longer study. And this is where the ABC study has been launched in 2015, and it is aimed to follow these kids for 10 years and see any of the changes of their neurocognitive and other outcomes. Is marijuana a gateway drug? So in a lab, rats previously administered THC showed heightened behavior response not only when they were exposed to THC, but also when they're exposed to other drugs such as morphine. And this phenomenon is called cross-sensitization. And these findings are consistent with the idea of marijuana as possibly being a gateway drug. Also, the cross-sensitization is not unique to marijuana. Alcohol and nicotine also prime the brain for a heightened response to other drugs. And like marijuana, also typically used before the person progresses to other harmful substance. It is important, however, to note that factors besides biological mechanisms, such as person's social environment, is also crucial at a person's risk of using drug. An alternative way to gateway drug hypothesis is people who are more vulnerable to drug taking are simply more likely to start at a readily available substance such as marijuana, tobacco, or alcohol, and their subsequent social interaction with others who use drug increase their chance of trying other drugs. So further research is needed to explore this area. Treatment. So medication studies for treatment of cannabis use disorder. The following behavioral treatment has shown promises: cognitive behavioral therapy, contingency management, motivational enhancement therapy. Currently, there's no medication indicated for treatment of marijuana use, but research is active in this area. Of the listed below, only N-acetylcysteine had an 8-week, double-blinded, randomized, placebo-controlled trial, treatment-seeking cannabis-independent adolescents ages 15 to 21. They had about 116 participants, where they gave them N-acetylcysteine 120 milligrams or a placebo twice a day, as well combined with a contingency management intervention and a brief weekly sensation counseling. What they found was that it doubled the odds of having a negative urine cannabinoid test as compared to the placebo, and the benefits was detectable within the first week of initiation treatment. For cannabis-dependent patients who have discontinued use, gabapentin substantially helped reduce withdrawal symptoms. FAAH inhibitor, which is fatty acid amide hydrolase, has been studied with N-acetylcysteine, which may reduce withdrawal by inhibiting the breakdown of the body's own cannabinoids. Future direction, including the study of a substance called allosteric modulators that interact with the cannabinoid receptors to inhibit THC rewarding effects. So you may have heard a couple things that cannabis is helpful for, such as nausea, glaucoma, inflammation, multiple sclerosis, chronic pain, etc. The FDA approved several marijuana-based products, including the synthetic form Marinol, which is prescribed to help with appetite loss and nausea in conditions such as AIDS. The synthetic cannabinoid Nebinol, which also demonstrate benefit to help with the treatment of PTSD symptoms. Also Nebuxamol, which is also an oral mucosal spray that delivers both THC and cannabidiol, which helps with treatment for neuropathic pain, disrupt sleep, spasticity in patients with multiple sclerosis. That is currently approved in the United Kingdom and Canada, but it's currently in phase 3 in the United States. So there are still some cannabidiol oil that are still being they're still being studied in adolescents for ADHD, anxiety, and autism. There's one in autism right now, it's in clinical phase trial 2, and also schizophrenia, Tourette's, and substance use disorder. But there's only one cannabis-based medicine that's FDA approved for adolescents, and that is Epidiolex. So this was a multinational randomized double-blind trial with an adjuvant cannabidiol versus placebo in children and young adult ages 2 to 18 years old with the Duval syndrome, whose seizures were not controlled by their current anti-epileptic drug regimen. So what they found was that the mean frequency of convulsion seizures per month decreased from 12.1 to 5.9 with cannabidiol, as compared to a decrease from 14.9 to 14.1 with placebo. So you might ask, what's the difference between the CBD oil over the counter versus the Epidiolex? Aren't they the same drug? Well, they're both cannabidiol, but what they differ is in their purity and the regulatory status. Epidiolex is a Schedule 5 prescribed drug, and it has it's the lowest level of regulation for controlled substance. CBD oil over the counter is legal in some states and it is an extract from the hemp plant. But the problem is the term purity. So there was a study where they took 84 online products of CBD oil and they tested them. And they only found that 30% contained the amount of CBD on the label, and then 20% contained THC in it. So according to the FDA, for it to be a prescribed FDA-approved cannabidiol oil, it has to be less than 0.1% of THC in the bottle. So that's how that's being regulated. All right. Any questions?
thought that was a great presentation, Samar. You know, about the issue of marijuana use in adolescence and later psychosis. There's been a good number of studies, we talked about it a little bit, showing an increased risk. Robin Murray's group, for one, and still certainly most who use don't later develop psychotic symptoms. So one of the ideas has been that it's a genetic interaction. You briefly raised that, but it's more specific in that the focus has been on a single point mutation in COMT, which is responsible for the metabolism of dopamine, which of course it makes sense in the increased likelihood of psychotic symptoms. So I don't know if you might have more to say about that.
Yeah, the COMT, when you mentioned that, there was one study on rats. They'd done that too, right? Is that the one that you were talking about, probably? Okay.
Well, there's been actually studies done of both in humans and rats on the disposition.
Thank you. I haven't seen the human one, but I definitely saw the rat one. But yeah, that is one of the point mutations. Thank you. Yeah.
So, you know, I think, as you said, there's a lot more questions and wondering about what we can, you know, what is real, what's really valid, what isn't. So, do you have any thoughts on how one should maybe respond to, say, parents in particular, who might want to find out, you know, how serious is this for my kid? What should I be looking at? What do you think, based on all of the reviews that we can kind of say about it?
I would say, if it was my kid and I found out my kid was smoking marijuana, I would probably educate them about the risks regarding about smoking it, and also just keep an eye on them. Maybe also, there's some families that actually moved to legalized marijuana states so that they can monitor their kid getting the marijuana to make sure that it's a more pure marijuana. So yeah, so it's a really tough question, but yeah.
So the kinds of things you're going to say is that they might get bronchitis, they might have more likely to get other drugs, they might have some, I don't know if the IQ point was necessarily verified per se. So there are some small specific points that you might suggest.
Yeah, definitely. I would definitely highlight some of the risk factors, but then again, I don't want to be turned offish, so that way that they can keep the lines of communication open, you know, so just kind of be there for them, but yeah. Yes? Oh.
So I think your question about that question and the importance of keeping lines of communication open is really important. So we would still use DSM-5 criteria. So you look at impact on life. You know, are they failing in school? Are they showing up to school? Are they interacting with other kids, or are they starting to only just stay with stoners? Are they engaged in activities? So you would start to look at impact, like you would any other condition. So I think that would be really important in addition to risk factors. And then the other thing is build in, try to add some of those protective factors. So try to find some community activities that your kid would get excited about that they might be willing to join. Improve family connectedness. Set up some rituals. Make sure the family's actually connected. You know, a lot of adolescents, nobody even eats together anymore. Everybody comes in, eats at their own time, and goes and does their own thing, or they go to their own rooms. Or I mean, it's really sad and tragic what a lot of families are doing now. Kids aren't even smoking. So I think there's a bunch of things on the protective side that you would counsel parents to try to do. But like you say, you don't want to disrupt those lines of communication where your kid doesn't tell you. Because if they're telling you they're using, hooray, that's at least, you know, they're not sneaking. That's a good thing, you know, always a good thing. If they tell you they're having sex, yay, not that you want to hear that, but now you can help, you know, you can intervene. But if they keep it all secret, you're just really screwed. You know, you're always trying to find out, and adolescents are good. You know, it's secret.
You know, also, there's always, when it comes to the marijuana, we think about the legalizing or illegal, you know, use of it, but it's the same thing for the tobacco. I mean, what would you do when your son or your daughter comes and you recognize that they are smoking cigarettes or the alcohol? Of course, many places that they legalize this marijuana, they still have this age, limited use about 21. So I think the approach would be the same way we do for the other, substances. But still, as Dr. Bird said, that there's addiction potential there. And also I want to add something, the frequency of the use of the marijuana and effect of that one to the lung disease compared to the tobacco, if you look at it. People don't use like 20 joints every day for the marijuana. Some people do, but most of the time it's very limited numbers of the joints that they use during the day compared to the cigarettes or tobacco use that they are mostly, a pack a day is pretty much average that they are using. So in different ages, so that would be the difference in the effect of the lung disease and things like that. And plus the second thing that I want to point out is most of these drug tests that we do, it does have a false positive, and people need to pay attention to that one. For example, NSAID can turn those tests to the positive marijuana, which is not a thing. That you need to always take caution to mark someone with the marijuana use when you start doing the urine drug screening, especially for the kids. If there is I don't know if the school has a rule to do the drug test or not, but they usually use those quick cups that you put the picture on it, and it does have a high false positive if someone take ibuprofen or naproxen.
Yeah. Thank you for sharing. Any other questions? All right, thank you. Oh.
One slide that you sort of alert, showed the CBD receptor working on the NMDA, CBD was working on the NMDA receptor or the GABA pathway. And then the slide said that marijuana was causing depression and anxiety. And then another slide, I think it was one of the last ones you mentioned that it's being used to treat depression and anxiety. I was just curious as to whether or not you knew which pathway was being used. Because like with the NMDA receptor, you have an excitatory pathway. With the GABA receptor, you've got an inhibitory pathway. I'm just curious if you or anyone else had any, and whether or not which way you lean personally, whether it was inducing anxiety and depression or treating it.
I just want to make sure I get the question correct. You said that about the pathways and if it affects depression, and then they use the treatment for depression, and then something about NMDA receptor.
I was just curious if you knew how, like one of the slides showed that it interacted with those two.
This slide?
Yeah, right there.
Okay.
So blue pathway, I apologize, which leads to the NMDA receptor. And then the GABA, I was wondering if you had any inclination of which way or how the mechanism actually worked there.
So from my knowledge, it does not work on the NMDA receptor. It's on the presynaptic receptor of the actual neuron that releases GABA. So the CBD receptor's on that. And then, am I answering, kind of getting to your question? Okay. And then it gets the CBD receptor 1 gets activated either by an endocannabinoid or an exogenous, so like THC. And then from there, it'll inhibit the release of GABA into the postsynaptic. So it doesn't go through the NMDA receptor.
Thank you. So would you say then that it could be used for anxiety as opposed to like causing anxiety?
Is it used for anxiety versus not? Is that?
With like one of the slides mentioned that it induces anxiety, marijuana use.
Did it say that? So no, I think I think the one about this one, right? Hold on. This one, right?
Yes.
The risk of increasing anxiety. So long-term use, is that, you said treatment.
Do you think like, I mean, one of the last slides I think you mentioned that they were coming up with like an years to like treat anxiety. Is that true?
I didn't see that treatment for anxiety for kids.
I don't mention seizures, but I'm just curious.
Okay. So, okay, yes. So this is where cannabidiol might be helping with anxiety versus THC.
Okay.
So,
Thank you. Sorry.
no, you're fine. I would have to get back to you on that. Or maybe Dr. Kendall can answer that. No, go ahead.
Thank you. It's interesting when you look at Alan Shadler's literature on treating psychotic depression, there's a disproportionate amount of glutamate as an excitatory neurotransmitter and not much GABA. We found that if you give someone mifepristone, if they have psychotic depression, and these are the same individuals who test with a dexamethasone suppression test. The mifepristone will rapidly downregulate glucocorticoid receptors, and in doing so, through a second messenger system, GABA and glutamate, it causes an influx of GABA, which leads to an actual increase in endocannabinoids through that second messenger system. And that causes an increase in dopamine throughout the beta ganglia, and it tracks back up to the nucleus accumbens, the ETA. Excuse me. So in retrospect, through endocannabinoids, you can actually increase dopamine, and the trigger for that is the second messenger system that Dr. Riaz described, which increases GABA. So many of the medications we're using now do work through a second messenger system. And what we're finding is if you can tap into the glucocorticoid, you can actually work through the endocannabinoids to increase dopamine. So there's a real possibility, like with the cannabidiol oils, that you're working through a GABA system or amino acid neurotransmitter system to, through the endocannabinoid system, increase dopamine. So no wonder we're researching right now and trying to understand, and I think it brings up an entirely new paradigm for all of us, which is, and I think Dr. Berg did it perfectly, no matter what the substance is, the fundamental question is it causing a problem? And this is going to be tantamount to the practice of probably everybody in this room, because what we're finding is what we used to call drugs of abuse, psilocybin, ecstasy, marijuana, ketamine, etc., are turning out to be quite good medications for both anxiety and depression. And the vast majority of those are going to be working through second messenger systems. And like Dr. Riaz just said, GABA, glutamate, and endocannabinoids can be key to that process. So I think we need to reel it back to the most basic thing, which is what Dr. Bird said. Is it dysfunctional? Is it dysfunctional? Or for a long time, have a lot of people been self-medicating? I think that's a very important question, a fundamental question, because it's really the here and now that we're treating people with what we used to call drugs of abuse. I think we need to keep that in mind. But all things considered, through GABA, through endocannabinoids, you can increase dopamine and do a lot of the treatment for what we're doing right now in depression and anxiety. Sorry about that.
No, thank you so much. Any other questions?
It would be good if you showed your references.
Oh.
Just in case, just so people can kind of get a feel, and they can get it from the site also.
Okay.
I know you had a reference list.
Yeah, I have a
Just so
lot.
people know you're not making this all up.
All right, thanks.